And it's that second space there that I'm going to place it, but I want to hit the top of the third rib. What lies underneath the ribs? Nerves and arteries and veins. We don't nick that. So if you hit the top of that third rib, it's safer than kind of hitting the bottom of it. Now what we don't want is once we introduce this hole into a patient, if there is the likelihood that it may not have tension, we're going to talk about that in a minute, this little valve system prevents it from becoming a tension. I'll show you what it does. It's like a dwell cath. Remember those dwell caths? Heimlich valves that we used to have? Again, you can carry those if you want to. But I have a 14 gauge because some dude told me to carry them now. And I have 10 ml syringes because some dude told me to carry them. And I have gloves because my nurse will kill me if I don't carry my gloves. Right? Because we're all good with infection control. Good job. And all I do is I take my gloved finger, just any gloved finger, and put it back in the cap. This is the only time we can resheath. Now remember, it hasn't stuck a patient. So if you stick yourself, it's at least clean. And all I do is I reintroduce the cannula back into the glove. And with my second intercostal space, confirming either jugular vein distension, tracheal deviation, subcutaneous emphysema. If we have the resource, x-ray, and listen, not going to hear that out in the field or in the home, because I simply don't carry x-rays in my back pocket. We need to confirm our clinical findings. The best way is that tracheal deviation. That is our clear signs that this is a tension pneumothorax. Now it can happen spontaneously. We know that. And if we're going to place this, whether it be left or right, just remember if you're on left, watch your anatomy. Yeah, there's some really interesting things you really don't want to hit with a sharp object. Alright, so you give that a bit of a clean and at 90 degrees to the patient. Make sense? Because if I go 90 degrees, I'm going to hit that second rib. I don't want to nick that at all. Whereas if you go 90 degrees to the patient, once you've identified those two ribs, you're going to hit the top of the third. And we press down firmly until we feel a pop. Yep? Yep. And what usually automatically happens because of pressure, you see that? The plunger moves up, I don't have to pull it, the plunger moves up and it starts to bubble. And if I get red, we need to do a chest drain. Not just tension, this is also a hemo as well. Happy?
Yep.
Now I don't want to advance the sharp.